Assalamu alaikum and good afternoon. I welcome you to the 19th Shaukat Cancer Hospital Symposium. My name is Dr. Rizwan Sheikh. I am a consultant medical oncologist in Shaukat Hospital. This is COVID-19 and cancer care session. And you all know that COVID-19 has affected around 50 million people all around the world. And there are 1.2 million people died because of this. It has affected the life of every person all over the world, directly or indirectly. As the economies of the countries are affected, their jobs are affected. Similarly, there are other issues related to this pandemic. Patients with chronic illnesses who were getting continuous care from the hospitals, their care was affected. These include chronic patients with chronic illnesses like diabetes with their complication, rheumatic heart diseases or rheumatoid arthritis and connective tissue diseases patients, cardiovascular diseases patient. Similarly, cancer care was disrupted because of the lockdown and also because of the effects of it. So when we talk about cancer care and COVID-19, just to make it easy for all the attendees who are attending this session, when we talk about COVID-19 era, we always talk about the effect of COVID-19 pandemic lockdown on cancer care and the recovery period and how we are preparing for the future. And similarly, when we are talking about cancer care, we are talking about different cancer care, like we are talking about diagnostic services, which include screening services for, as you all know, it's a mammographic screening for breast cancer, colorectal cancer screening. Similarly, diagnostic procedures, which include radiology, which include procedures like endoscopies, biopsies. Obviously, they were affected. And after that, surgical treatment were delayed. Medical oncology treatment, which includes not only chemotherapy, immunotherapy, and other targeted therapy, they were disrupted because of its effect. And similarly, in addition to that, radiotherapy services, clinical trials, and patients who are on a chronic follow-up, their follow-up was also disrupted. So before I introduce my first speaker, I would like to tell you a little bit of housekeeping rules, which are basically, I have 4 speakers from 4 different regions, from 4 different countries. And each talk is of 20 minutes. And after the 4 talks, we will have question and answer session at the end. And after that, if time permits, we will talk a little bit about the 4 multiple choice questions at the end. So, so my first speaker is a professor of medicine and medical oncology in University Hospital, Galway. He is an inspiration for me personally. In addition, he has a special interest in the management of breast cancer, clinical trials, translational medicine. So I would like to invite my first speaker, Professor Dr. McKean, to present the first talk, which is impact of COVID-19 pandemic on cancer early diagnosis, treatment, and guidelines for management. So kindly share your presentation.
Well, Rizwan, I want to thank you very much for that really kind invitation. And I greatly appreciate you calling me and asking me to give this talk. You know, it's because of this virus that I'm giving this talk from home and not giving it in person. But it is a real pleasure to speak to you at this cancer symposium in Pakistan, and particularly because I suppose from a personal standpoint, like yourself, Rizwan, I would have had very many junior staff members from Pakistan, many of whom have been absolutely stellar working in my service. And it's a pleasure for me personally to be able to give back a little bit by giving this talk. So with that, I'm just going to share my screen. Have you seen that?
Yes, yes, it's fine.
Are you seeing the front slide?
Yes, and this is the first slide, yeah.
Okay, so if you can see that, and I hope everybody can see that fairly clearly, what we're going to talk about today is the impact that COVID-19 has had on us here in Ireland. Now, obviously, we're a small, much smaller society than you are in Pakistan. We have a huge advantage in that we're an island, so that we do have opportunities to seal our borders in a way that perhaps others don't. And what I'm going to talk about today is really the first wave of the infection that came through. Now, just as part of background, I'm a medical oncologist, as Rizwan has spoken about, with an interest specifically in breast cancer and breast cancer research. But I'm also the national advisor in medical oncology to our National Cancer Control Program. So very much it fell to the National Cancer Control Program at the time of the outbreak of the virus to deal with this virus in the context of trying to treat patients with cancer. So we all know what happened internationally, but just to very briefly show you what happened nationally in Ireland, this was the timeline of how this disease happened here. We clearly knew things were coming from the east. Wuhan, China, had already had issues. By the time it was coming towards Ireland, the biggest issues really were in northern Italy and in southern Germany. And the first case in Ireland diagnosed on February 29th of COVID-19 was actually a GP from County Clare, south of here, who had gone on holidays with his family and returned to Ireland. As we came into the month of March, we obviously started to see more cases. Our first death was actually on March 11th. Now, March is kind of important in Ireland because our national holiday, St. Patrick's Day, is on the 17th of March. And that's usually a day when people party quite a lot. So in Ireland, while this wouldn't matter in Pakistan, in Ireland it does. They closed the pubs on March 15th, so nobody could go out. And that actually heralded what ultimately was a full lockdown. So this was the knowledge that we had in terms of what was happening at the time. And at the same time, I suppose the knowledge that we also had was we had some idea of how this virus behaved. We knew that we had about 3 days of asymptomatic period when patients largely were well, had been exposed, had not yet been infected, but started to replicate virus. We also knew that this period of replication was probably not a very high transmission rate because people weren't symptomatic. But once they got into the symptomatic phase, things were going to be significant in terms of viral transmission. And of course, as we've later known now that once that acute phase is over, the inflammatory phase is really what heralds the severe disease, the disease that has killed quite a few people, as we know about, and thereafterwards people went into recovery. Now, at the time, the only hard information we had from China, specifically where we had one significant publication, was we knew that there were some vulnerable groups. So vulnerable groups, we knew, for instance, specifically included lymphopenics, patients without the adequate white cell function to actually deal with the virus. We knew respiratory disease was particularly going to be a problem, given the fact that this was a respiratory illness. At this time, this disease in this country was killing 1 in 5 people over the age of 80. We've got much better at dealing with it now. We're only 1 in 20 dying in that group, but we really didn't have an awful lot of knowledge about cancer. So those are the two. So we knew what was coming, and we basically knew what the course of the disease was. Now, we were lucky in a couple of things, and this was probably our most lucky thing. This isn't a medical slide. This is a political slide. So we had an election, a general election on the 8th of February. So before we had a case. And in that election, there was largely a dead heat between three political parties. You'll know all about political issues in Pakistan. What it meant is we had no formal government on the 27th of June. And that was a major advantage because it meant no politicians were making decisions. The decisions were made by our Department of Health and made by our Chief Medical Officer. And what it meant is that science drove what was happening and not politics. So it gave us a really important healthcare opportunity to deliver on what we needed to do. The second thing we had that was very advantageous is in 2006, we established a National Cancer Control Program. Now, the National Cancer Control Program is a component of our health service executive, which delivers all of our cancer care in the country. And that delivery of cancer care is delivered through a series of 8 cancer centers. We treat all of the adult malignancies. We have one pediatric center that does the pediatric work. There are a couple of subspecialized centers. But what it means is that we have a formal national mechanism for connecting all of our cancer care. So with that as background, what we decided to do as a cancer control program right up front was, number one, we shut down all our screening services. What we didn't, so our bowel screen, cervical screen, breast check, we also run the diabetic screening service, we shut those down. The reason we shut those down is we did not want to make a diagnosis of early disease with a good prognosis in a group of patients where we potentially could open them to a lethal event by bringing them into a healthcare environment that was potentially or possibly going to be overwhelmed by a virus about which we knew at that time actually very little. What we did in contrast was we increased services through our rapid access clinics. So we have rapid access lung clinics, prostate clinics, breast clinics. So we increased rapid access to them, made that more accessible, so that anybody, even with early symptoms, got seen quickly. This was a balancing act. I'd have to say, I think it was a very good decision. This also yielded up very many, for instance, radiographers who became critical in terms of the management of COVID-19. So all of this was the prep work. So from a systemic treatment standpoint, or a medical oncology standpoint, here's what we did. So through the NCCP, the Irish Society of Medical Oncologists, which is all of our medical oncologists in the country, and you've got to remember, we're a very small country. In total, we have 40 medical oncologists in the country. And our Irish Society of Hematologists set up a weekly meeting. And in that weekly meeting, we basically updated each other as to what was going on in every cancer center in the country. We updated each other as to complications and problems we were running into. And through the cancer control program from that meeting, on the HSE website, we established a single page where we outputted the outcome from this so they could be implemented nationally. There was no email connections, there was no phone calls. It was all a single website so that everybody knew in real time what needed to be done and how to do it. So that was really how we set up the system to approach the management of systemic treatment nationally over the period of the virus. And at this time, obviously, we had very little information, okay? What we did have, for instance, this was a Nature Reviews clinical oncology paper from April. What we did have is we had a mechanism for prioritizing cancer treatment from very low priority treatments, such as where there's alternate treatments or just palliative care, right through to very high priority treatments where people were imminently at risk of dying, acute leukemia, aggressive lymphomas, germ cell cancers. So we knew we had that spectrum of disease to deal with in a context where we were really quite ignorant of what the potential impact was of the virus. And that's really what we wrestled with as a group. And so what we did was we did a risk-benefit analysis for what we were doing, where we had the cancer, patients with cancer, which was a known disease that they actually had. And we tried to counterbalance that against coronavirus, which was a disease, the risks of which we weren't fully aware of, but we knew were high in some groups, but with patients did not have. And the outcome of those deliberations ultimately is that we decided as a group formally that we would treat cancer as per standard of care, that we would try to mitigate the risk to the vulnerable, and we would try to mitigate the risk to the health services. So what information did we use to do that? Well, the information we used was this. At that time, and indeed today, the very best evidence preventing SARS-CoV-2 infection are number one, hand washing. Number one. It's so boring. It's what you tell a 3-year-old child, wash your hands, wash your hands, wash your hands. But it is so core, and social distancing. Now, through our Department of Health, we had a national program of information, which was around coronavirus COVID-19, which was keeping the public informed of this. What we simply did was amplify this within the healthcare environment, and particularly within our day wards. So how did we do that? Well, here's what we did. Well, the core messages were this. The single most important thing we did was we set up a telephone triage system. So every single patient who was coming for systemic therapy for cancer, irrespective of the systemic therapy, got called the day before to ask them if they were symptomatic or at any contacts. I would say to you that was the single best thing that we did. It prevented the disease, COVID, getting into our day wards. As much as possible, nationally, we created independent teams. So we created, for instance, in medical oncology, we split our junior staff into 2 groups who didn't interact with each other. We split our nurses into 2 groups who didn't interact with each other or live with each other. Our most difficult area was in pharmacy, because in pharmacy, we actually were quite limited in the numbers of pharmacists we had. And so we had a vulnerability around pharmacy if pharmacy went down with somebody who got infected. We advised, but we didn't demand, that senior staff got withdrawn from the patient front. So what we did is, let's say you had a senior nurse in oncology who was hanging chemo bags. Instead of that, what we did was put a very junior nurse in there, and the senior nurse supervised her, so that if somebody was going to go out, it was going to be the junior person and it wasn't going to be the senior person. We did change regimen somewhat. So in terms of chemotherapy, where, for instance, for example, you could give carboplatin and Taxol as a weekly regimen for, say, ovarian cancer, we changed that to a 3-weekly regimen. Where we had regimens that were profoundly lymphopenic and have really, moderate benefits, or, for example, I would say rituximab in maintenance therapy for lymphomas, we simply held on those regimens altogether. So we implemented these measures, as I say, through the website. In terms of structural measures, the most important learnings were these. We had many of our oncology day wards that were in the middle of acute general hospitals. What we did is we took them out of the hospitals and created a separate entrance, so that the footfall through the day ward was different to the footfall through the hospital. That prevented people getting exposed. We ensured social distancing, that all chairs were more than 2 meters apart, and patients in day wards who were vulnerable, respiratory illnesses, lymphopenics, we treated in isolation. So in other words, in rooms where there was only themselves. So those were really the core things we did. And basically what you can see what we did was we guaranteed social distancing, and we just made sure that everything was clean. We communicated this, as I say, through our website, and once a week this was updated, and every unit in the country got the same message, and every unit in the country could rely on that to be a message that was structured to be informative to all of the management within their hospital to deliver that care. So how did it work out? Well, I have to admit, we got lucky. So every single unit remained open. There were exposures in a few units, but these were contained. Systemic therapy for cancer went ahead totally uninterrupted in every unit in the country. So we managed to continue to treat throughout the whole pandemic. And indeed, in this second wave that we're getting now, we have simply implemented this. We have continued the same processes. Where did we fail? We had one, I would say, significant failure nationally, and that is in our A&E departments. So what happened is that in A&E departments, patients were split between admissions as for potentially COVID versus non-COVID. Now, as you all know, anybody with febrile neutropenia comes in with a fever and feeling sick. Well, that's what you get when you get COVID. So unfortunately, many of our sick patients, or patients with PEs, for instance, come in short of breath, many of our sickest patients coming in through our A&E departments went in through the so-called COVID stream. That meant that they were isolated. It meant that the numbers of nurses involved with them was small. And so what it actually meant is it probably delayed active management. Now, we're working at that at the moment, again, through a telephone system, that those patients get almost over-treated on admission for their cancer-related problems. And hopefully that will help us get through this second wave. Now, obviously, things have changed since we started in March. We have 2 major groups internationally. There's the SKCS-Cancer group, which is the COVID-19 Cancer Consortium group. We also have the UK Coronavirus Cancer Monitoring Project, both of whom have published in the Lancet. And personally, I am the PI for the SKCS-Cancer group in Ireland. So what we're doing is we're putting all patients who present with COVID and who have cancer in Ireland on a data website. And I would encourage anybody to do this. Anybody can join it. And what it means is we're collecting hard data. And the hard data are now showing us that indeed in other institutions as well, other countries as well as Ireland, we can readily treat cancer through COVID-19. The risks are not excessive, except for a couple of specific groups, particularly those like CLL and with severe respiratory illness. So a lot of the experience internationally would reflect what we've had here in Ireland. The key learnings, number one, we were lucky in that we had a rapid response system. I think one has to have a rapid response system within a pandemic to apply any learnings that are coming through or that we gain collectively from talking to each other. And we need to be able to communicate that extremely rapidly. And in our case, we used website communication to deal with that. So with that, I'll just say thank you very much. I think you're muted.
So thank you, Professor McEnkeen, for an excellent presentation. And I know that this is a great model. Obviously, you did very well. And now I would like, obviously, question and answer session will be at the end. But I would like to invite my next speaker. He's a professor as well in medical oncology in University of Sheffield. His special interests are management of urological cancer, clinical trials, early drug development, and translational medicine. So Professor Syed Hussain will present impact of COVID-19 on systemic anti-cancer treatment and clinical trials and management for the future. So Professor Syed Hussain, kindly share your presentation with us.
Good morning. Is it sharing now? You can see that?
Yes, I can see that, yeah.
Okay, Assalamu alaikum. And again, thank you very much for inviting me to attend this session and give this talk. Again, a very impressive talk by Professor McEnkeen. I'm really impressed with that, and we'll touch base with him later. So today I will really be trying to set some sort of a background on the work we did in our center in Sheffield. So I'm a GU oncologist, and my major practice is quite significant bladder cancer and prostate cancer practice and some kidney cancers. But the key things here is that when coronavirus came in, there was so much sort of confusion around it, that how do we manage these cancer patients? And I really enjoyed the talk by Professor McEnkeen given about talking about the background, how they set up their services. So moving forward, these are my disclosures. So COVID-19, as we talked about, is a worldwide pandemic. It affected, this is from a while ago, and the number of patients have continued to increase. This is from when I had the first data around in mid-July, when I looked at all the data. Early evidence suggested that cancer patients with underlying malignancy and impaired immune systems from disease or from treatment, or both, are at high risk of poor outcomes. And I think that's a key thing. What we really needed to understand is that what is the risk from COVID-19 and what is the actual risk from advanced metastatic cancers. We are continuing to learn more through the course of this pandemic, with more recent data suggesting that the risk for these patients are mainly driven by age, gender, and comorbidities, as is the case in general population. And our cancer patients are generally elderly patient population. Quite often they will be getting letters from shielding. I remember every week patients ask me the question that I've got another letter about shielding. And when they're coming for advanced cancer treatments, I think it's important that they continue with these treatments as well. So NICE had published guidelines, and that was the background, which was telling us to maximize the safety of cancer patients, make the best use of NHS resources, and protect staff from infection during the COVID-19 pandemic. And this was an interesting guidance, which was giving more like a sort of a guidance to colleagues around nationally, and some of the international sites were looking at that guidance as well. Communicating with and supporting patients and minimizing face-to-face contact. And this was, again, an interesting concept, which has led to many innovations in our delivery of services. But at the same time, I don't know how many of you would feel that, but as medical oncologists, when we're giving systemic chemotherapy to patients who are borderline fit, sometimes face-to-face contact is quite important for us to assess their fitness, especially in this sort of a coronavirus environment, COVID-19, where we have to look at the risk versus benefit very carefully at each and every visit. And then prioritizing systemic anti-cancer treatment. So these were the key things that were there. If you look at this priority level, you will see many of the cases that we treat for cancers would have been out of that sort of first three priority levels. So curative treatment, priority level 1, curative treatment with an intermediate 20 to 50% chance of success was level 2. Priority level 3 was curative treatment with a low chance of success of having a cure, 10 to 20%. And then curative treatment with very low chance of success, 0 to 10%. But then non-curative treatment, which many of us are involved with, was a priority level 5, where there is a more than 50% chance of palliation. And number 6 was non-curative treatment with an intermediate chance of palliation or temporary tumor control and less than 1 year expected extension of life. And many of you will feel in that boat where we are treating patients with priority level 5 and 6. And I think that is where my concern was, that are we starting to consider the sea of coronavirus being much bigger than the sea of cancer? And that was something we wanted to look at. So the aim of this project was to evaluate the impact of COVID-19 on clinical practice for urology cancer patients under my care. So it was a single sort of a consultant level care. Again, I had quite a big practice in terms of the bladder cancer patients, prostate cancer patients, and especially the advanced metastatic disease patients. Again, these are elderly patient population whose median age is in their late 60s and early 70s. Data was collected retrospectively from electronic patient records and chemocare. This included patients who were treated with chemotherapy, immunotherapy, or as part of a clinical trial from 1st March 2020 to 30th of June 2020. Again, what is quite interesting here to see is that we were running trials of chemotherapy plus immunotherapy. We had significant immunotherapy trials. And when I was talking to these patients, I was always asking them about whether they would like to continue with the treatment, knowing the risks and knowing the uncertainty that was there about if we give chemotherapy, does it and how significantly it increases the COVID-19 risk. Patients visit to the hospital, how significantly it increases those risks as well. So all patients were screened. So those were the mitigating factors and things that we were doing, as Professor Keane told as well, about screening patients and making sure having distancing, social distancing and things like that, that did play a key role in keeping those infection rate low. So all patients were screened on arrival to hospital and also on day case unit for COVID-19 symptoms and contacts. All patients were counseled about the potential risk with COVID-19 and the implications should they require hospitalization. And this was quite a surreal discussion because we were being told that if I'm treating patients or if we are treating patients, HDU and the ITU facilities were being overstretched. So whether a cancer patient will manage to get a bed there, I think there were huge question marks around it. So those were the questions and those were the issues that were being discussed in the real world setting. And I think it was quite difficult for the patient to understand that we're giving them palliative treatment, but if things go wrong, which could well be reversible, whether ITU will be able to take, whether ITU will have any capacity to take those patients at all because of the increasing numbers of COVID-19 patients that were coming in, and the hospitals were getting ready and getting prepared with it. And actually, there was a time when it was being overstretched. Patients made an informed decision of proceeding with or stopping treatment, and these discussions were documented in the medical notes. Total number of patients during those periods from 1st of March to 30th of June, number of new patients was 61, palliative patients were 43, neoadjuvant 10, adjuvant 8. Median age was 71 years, range 47 to 80. Comorbidities were present in 51 patients. Most common were hypertension, hearing impairment, hypercholesterolemia, and diabetes mellitus. Primary cancer, bladder cancer was 44, upper urinary tract cancer 7, prostate cancer 10. Metastatic sites, lymph nodes only 9, and visceral metastasis 35. So quite a significant number of patients with advanced disease and with visceral metastasis, so in terms of palliative setting. Total number of cycles that we administered during that period was 195. Immune oncology for locally advanced metastatic urothelial cancer, 51 cycles of atezolizumab in 12 patients, 8 cycles of pembrolizumab in 2 patients. In terms of chemotherapy, mainly cisplatin gemcitabine in 5 patients, 15 cycles. A split dose cisplatin and gemcitabine with day 1 and day 8 cisplatin in 15 patients, 33 cycles during that period. Carbogem, 7 cycles. Carboetoposide, 7 cycles in small cell type of patients. Then paclitaxel, more as a third-line treatment. Docetaxel in prostate cancer, upfront chemotherapy, castration-sensitive prostate cancer setting. Then we had trials ongoing that included Javelin, that was looking at avelumab. In that setting, we had Niagara trial going on, which was looking at chemotherapy plus durvalumab in neoadjuvant setting. We had Potomac trial, which was looking at durvalumab in non-muscle invasive bladder cancer patients, and a strong trial, which was looking at durvalumab. Then EV301, which was a randomized trial looking at enfortumab, which is a conjugated anti-Nectin-4 antibody versus standard of choice chemotherapy, which was paclitaxel, docetaxel, or vinflunine. So those patients, we carried on with their trial treatments rather than stopping them. And again, what was interesting was that one male patient discontinued treatment due to IO toxicity, again, grade 2 hepatitis, continued on tapering dose of steroids and recovered completely. One female patient with metastatic bladder cancer developed immune-related grade 3 hepatitis. She was treated with tapering doses of steroids and mycophenolate because it was proving resistant, responding to steroids alone, and then was rechallenged with atezolizumab successfully. So I think the concern about the use of steroids and things were perhaps not as relevant as what we thought initially when it all started, because I know there were colleagues who were stopping to use IO based on the concern that if a patient get IO-related toxicity, could we use steroids? And now we have learned that actually steroids is a good part of management for COVID-19 anyway. One patient stopped chemotherapy after 3 out of planned 4 cycles of neoadjuvant chemotherapy as she developed transient ischemic attack, proceeded to radical cystectomy. One patient stopped following admissions in the hospital with neutropenic sepsis and grade 2 fatigue after 7 cycles of docetaxel in castration-resistant prostate cancer. 3 patients with stomach chemotherapy stopped due to disease progression, which will be in any case, in any setting. One patient stopped after 3 cycles of palliative chemotherapy with gem plus cisplatin after being admitted with treatment-related side effects, and she was the only one patient who tested positive for COVID-19. She was treated with antibiotics. CT scan showed stable disease. She was discharged home after 4 days of inpatient stay, and patient recovered and will be considered for second-line treatment when there is evidence of disease progression. So the 3 cycles of chemotherapy did help us to get a durable sort of a response in terms of stable disease that is still ongoing in that setting. Total number of admissions were 14, elective admissions were 3, emergency admissions were 5, emergency admissions at District General Hospital were 5, and review on a West assessment unit was 1. So what we are seeing here is a similar pattern that I will see in that we have looked, because this is under review in one of the journals where we have looked and we have put in another 4 months practice, which is very similar, and the total number of admissions and the number of cycles given were not any different to what was in a normal 4 months period previously. So our single center demonstrates, this data is demonstrating that treatment with systemic chemotherapy, immune checkpoint inhibitors, and the use of a steroid for toxicity management may be possible during the current COVID-19 pandemic. Only 1 patient in our cohort tested positive for COVID-19. Patients need to make informed choice after careful discussion with their oncologist. And that is really key, because these treatments, there are risks there. I don't think any one of us can deny that, but there are significant benefits. We have moved a long way over the last decade, over the last 10 years, in improving treatments for GU cancers, for bladder cancer that I treat, for prostate cancers we treat. We're bringing those treatments earlier and forward to our patients. We're moving from second line and third line metastatic to second line to first line to neoadjuvant settings now, and even coming into non-muscle invasive bladder cancers. So what I'm worried about that in terms of the COVID-19, the impact should not be that all the gains we made over the last decade, we lose that, because the risks from cancer, I think, outweighed the risk from the treatment. And I think that is the discussion we need to have. And we need to have careful review of risks from the disease versus risk from the treatment and potential benefits from the treatment. So I think that is the key message that I want to really give and leave you with because the second pandemic is here. It is a reality. We have to accept it. But I think we have to fight it with our patients. We have to look at the benefits that these treatments are bringing. Chemotherapy, because when you look at the priority level that came, when you look at the NICE guidance that came in March, that was very much like moving us towards more towards palliative sort of a setting where you just wait for patients and offer them best symptomatic support, best symptom support, which I think will be the wrong choice for many of these patients. I think we have started to see many patients coming to us, as Professor Keane said. I'm very impressed with how the Ireland dealt with the screening was important, but at the same time to park it for a while, but to continue with diagnostics, because we are starting to see patients coming through A&E now with advanced cancers, patients who've been sitting on their symptoms or have not gone through the phases, or have been shielding, or have been getting a message from the healthcare that perhaps it is better for them to stay at home because if they walk near a hospital, they will get COVID. So there are a lot of hypothetical concerns which have overtaken us. And I think as oncology community, it is important. And I'm really delighted for Shaukat Khanum to organize this meeting as well, and to keep COVID-19 on the forefront. And I'm really looking forward to hear from my other colleagues as well. I will stop here. I hope I have not taken time more than allotted. And thank you very much.
Thank you, Professor Hussain, for an excellent presentation. And obviously, we can learn a lot for management in the future as the second wave is ongoing across the world. So obviously, Ireland and UK looks like dealt with this COVID-19 very well, but how the other people dealt with it. Obviously, there are data that showed that obviously cancer services were disrupted, and obviously outcome of the cancer were affected because of it in some bigger countries. So let us invite my next speaker. He is a consultant surgical oncologist in Shaukat Khanum Memorial Cancer Hospital. He has a special interest in GI cancer surgery. So Dr. Shahid Khattak, kindly share your presentation.
Thank you very much for inviting me, Rizwan. Can you hear me?
Yes, I can, absolutely.
And let me show you my COVID and surgery. I think this is the one share screen. All right. And can you see my presentation now?
Yes, I can, absolutely.
All right.
Go
okay.
ahead, please.
For both the professors who are sitting in Galway and Yorkshire, this is Shaukat Khanum Hospital. You know, it is the view from the lakeside, and I'm Dr. Shahid Khattak. I'm one of the GI surgeons who are working in Department of Surgical Oncology. So we are going to talk about COVID and surgery. This is just a saying to start my presentation by Danielle Micini, that and there will be no more surgeons, urologists, orthopedic surgeons. We are only doctors who suddenly become part of the single team to face this tsunami. I will briefly go through this COVID worldwide statistics. As you can see, the number of cases, the number of deaths. I don't think so we need to go into detail of that. Most people know about it. This is the worldwide distribution, and our country is somewhere here, you know. So we are right in the middle of the world as well, but also in the middle of the figures, you know. We're not that dark, but not that light as well. So we had our fair share of COVID in this country as well. These are also some figures, you know, this is not the latest, you know, but a few weeks back. And overall, we had about 2.1% mortality from the positive cases. Now, coming to my topic, which is COVID and cancer, and then COVID, cancer, and surgery. As you know, COVID, cancer patients are immunocompromised, they are malnourished, and if they have comorbidities, that makes the things even worse. And on the figure on the right side shows, that the incidence of severe events is in non-cancer patient is here, and in the cancer patients, it's on this side. And this is the cancer survivors who had actually survived the disease in the past, and these are the one with the comorbidities, and this is the one with no comorbidities. And even here you can see there's a big difference, that the cancer patients don't do that well as the non-cancer patient if they get COVID. Now coming to the challenges in surgery, what happened at the start, that we had very limited experience about this disease and disease plus surgery. The data was really coming nearly every day, and the guidelines were changing every day. We were worried. There were a lot of information coming up. I mean, I do remember, because I was in those meetings, most of those meetings, which we at that time did on Zoom, which we are using today. Even we got an expert on in these Zoom meetings nowadays. But I saw one of the paper in which there was about 25% mortality after colorectal cancer surgery if they get COVID perioperatively. So that make you worried, that am I doing the right thing by operating on my patient? I mean, I'm a GI surgical oncologist, so I do esophaguses and rectums, and most of them have chemoradiation. So I have a window of about, say, 6 to 12 weeks to operate on them. And you just, sometimes you, at that stage, we're worrying, that whether I'm doing the correct thing by operating on them. Am I actually putting them more at risk, These were all the thoughts which I'm sure was coming in everybody's mind, and it was also coming in our mind. And we're looking at the risks to the patients, to the healthcare professionals. If the patient gets post-operative complication, it means that he will stay longer in the hospital. And if he stays longer in the hospital, there's more chance that he might get COVID. And at that time, in say February and March, there was a global shortage of protective gear everywhere around the world. And we were also there as well. So now looking at the local challenges, just like what Professor Keane has said, in Ireland, they got their first patient around in February, and they got their first death in March, COVID related. It was exactly the same here in Pakistan. At the end of February, we got our first case, and at the start of March, we got, unfortunately, our first death, which was in the north of the country from where I come from. So the start of March was really worrying, As you know, Pakistan is an underdeveloped country, so there are limited health resources. There's lack of ITU bed, lack of trained pulmonologists and ID guys and intensivists. And there was a lot of stress. Shaukat Khanum is considered to be a premier institution in this country, but obviously it's a cancer center, and we were under a lot of pressure from within ourselves that how we can help the country in this difficult times. So then it was decided that we will join hands with the government, and as we had one of the best pathology services in the country, so we helped them in testing, and that was, in fact, Shaukat Khanum was one of the first testing center for COVID in this country. Then we made numerous committees, for the surgical side, to look after the surgical side. ID guys were involved, anesthetists were involved, surgeons were involved. And we did an extensive review of the literature, which was coming nearly every day in end of February and in March. And even now, we reviewed the national guidelines, review of the local COVID statistics, which were, in fact, I mean, everybody at that stage were looking at the COVID meter through 2 or 3 times a day, and review of the resources we have, and the expected workload in the worst case and the best case scenarios. That if we get in a situation like Italy, what we will do. These were all the things which were on our mind, at that time. So Shaukat Khanum decided to join hands with the government, and initially we gave them we used our pathology service for the testing, and then we established a COVID camp, which was actually the parking area of the hospital was converted into a COVID camp where the patient could walk in if they were symptomatic, and they were examined and they were tested, and if they needed admission, they were admitted. We converted one full floor to COVID, and it was called Red Floor. So it was completely segregated from the rest of the hospital. We made a separate COVID ICU, and we even made plans that if we needed more patient for ventilation, so we had a plan that our pediatric ward will become additional COVID ITU, and we also made changes in the OR suites, so that they can be converted into ICU as well. I mean, let me tell you, it was a daunting task in that few weeks, because obviously to convert a floor into COVID floor, you have to put negative pressure. The rooms have to be negative pressure, so there was a lot of work to be done, and obviously, you need a space for that. So elective surgery at that stage, this was about start of March, I will say. We had a lot of discussion, and then we thought that we will postpone the elective surgery and we'll do only the emergency surgery. So, I mean, the decision was multifactorial. Number one is that we needed obviously a space in the hospital where we can put the COVID patient. But I think more important was that whether we thought that elective surgery is safe at this stage. So these were the two main reasons, that we took this bitter pill of postponing the elective surgery and performing only emergency surgery. In fact, we were given a 2 weeks warning time, we will say, in which we did as many elective cases as possible. And at that time, we were converting obviously the surgical floor to the COVID floor as well. And from 24th of March, we stopped elective surgery and started only emergency surgery. I mean, we did extensive review of the literature. I mean, I am so grateful to all the people who have contributed to this literature, because we were a bit behind in the queue. Obviously China and Italy got it, and the rest of Europe got it before us. So we learned a lot from the people who have contributed, their experience by publishing it. I'm so thankful to them and grateful to them. This is, just like these papers, in this paper, they say that they're quoting about 23.8% mortality for perioperative COVID in surgical settings. This is another brilliant paper, from Switzerland, where they have shared their response, that how in the first step they only canceled the non-oncological services, and in the second step they had to cancel the elective oncological services as well, and they converted their clinics to teleclinics, and also about the surgical workforce, how they actually managed that during that time. And it's an excellent paper which helped us a lot, that the countries which were affected earlier than ours, what was their experience. This is again some excellent publications regarding the head and neck surgery. And I must come to these two organizations, which published their guidelines. One was the American College of Surgeons in collaboration with the Association of Anesthetists in the US, and the Association of Colorectal Surgeons in England. They published their guidelines, and they were extremely helpful. to us in establishing our own guidelines regarding the elective surgery work. I actually, this is a busy slide, so I will won't go. I don't think we need to go through the whole slide, But it actually, these are from the American Association of Surgeons guidelines, and it divide the patient into three categories. The first one are the one that if they go through surgery and they get COVID, so that is unlikely to have excess mortality. So that is one category, while the third one is the one which are extremely likely to die from surgery and COVID. Our cases, our patients were mostly in the middle, because that if we operate on them and if they get COVID, they will probably have excess mortality, and will need ventilation support if required. And the second thing, which was again in these guidelines, was that what sort of environment are we working in? What type of hospital we are working in? I mean, the first category is a cold hospital, which is free from COVID-19 cases. I mean, the example of that are from National Health Service, just like in London, the NHS actually took over quite a few private hospitals, and made them cold center where they did oncologically major resections, and they were COVID free. So that was will be the example of E1 environment, while E3 is actually where there's a high prevalence of COVID-19 infection. And if you operate on patients, there's very much chance that they will get COVID infection. Again, we were right in the middle here. Our hospital, we had segregated service on the same site with an almost COVID-free cold facility, where we thought that we will start our elective surgery procedures. So we came up with our own local guidelines for restarting surgical services. We, as I said, we looked through the literature, and with the help of all these Royal College of Surgeons of Ireland, ASGBI, their guidelines, and we came up with our guidelines, that the patient must be asymptomatic and self-isolating for at least 14 days. So there were a lot of phone calls going on from the hospital. I have to admit, when we stopped these emergency surgery, most of my residents, although they love to be in ORs, but they were most of the time busy on the telephones, ringing patients, and finding out that whether they had any symptoms or not. So we used to use telephone calls for finding out, whether they're asymptomatic or not. Yes. Can you hear me?
Yes, I can.
And can you see my screen?
Yes, absolutely.
All right.
Please go ahead.
I think there's a little bit of a hiccup, All right. So by that time, we had enough kits available to test patients. So we decided that we will test all our preoperative patients within 48 hours of their operation. And if they were positive, then we'll postpone the surgery for 14 days. And in that 14 days, they were getting regular calls from the hospital, regarding their symptoms. And if they were asymptomatic, we used to reschedule them. We didn't do routine preoperative CTs because we thought that was really not needed. We reduced the OR staff to the minimum required. I have to admit again, we actually, at that stage when we decided to start our elective surgery, we made it consultant-led service. So operations were performed by the consultants rather than by trainees. And there was a strict compliance of level 2 PPEs, N95 masks, gowns, aprons, and eye protections. Very important, to monitor the supplies and the consumption rates, of these PPEs, and the risk and benefit of postponing the surgical oncology. I have to admit, Dr. Rizwan is here. He's a medical oncologist. And in that period, we have been speaking to each other on daily basis, via email or via telephone, discussing each and every case which was postponed, that whether whether he can give them for example, if it was a gastric cancer patient, usually we operate after 4 cycles of chemo, and I used to discuss it with him, and then we used to decide that we'll give him another cycle of chemo and operate after that. That was going on a daily basis, via email as well, and via on the phone call as well. And we were also looking at our workforce, and whether they're getting enough rest, and most of the clinic were actually converted to teleclinics to reduce the unnecessary exposure. So these were the measures which we took before we started our elective work. Now, looking at the timeline for restarting the surgical oncology, as I said at the start, that Pakistan was, I think, in the same time when Ireland got its first case and its first mortality. So in March, we got our most of our cases when it started to grow up, and we were given 2 weeks to start the preparation, and we did as many cases as possible in that 2 weeks. From 24th March, we did only emergency surgery for 2 weeks. And then we started with smaller cases and the day cases and the patients which need probably 1 day post-op admission, because we had the limited beds on one of the medical wards at that time. The surgical ward was taken over by the COVID patients. And with that planning, in the next few weeks, we were able to start all subspecialty surgery by 24th April. So it was about 1 month lag, where we didn't do that much elective work. And gradually we went to a full service. And now, sitting here today, I think we are at about, say, 90 to 95% of what we were doing last year on this date. We also shared our experience, on a couple of webinars at the end of May, that what we did and how we started our elective work. This is a little bit of data from the April to July, of the various subspecialties in surgery that we have performed. So we are nearly gone back to, as I said, 90% of what we used to do. This is the individual data from breast and then upper GI, about 70 upper GI cases, which included esophageal and gastric cancers. And as I was mentioning you that we let me take the screen. We were testing all the patients. So if you look at it, number of total cases were 70, and the number of COVID-19 positive were 7. So it's about, say, 10%, and they were asymptomatic, but we tested them before operation. This is a colorectal surgery, about 195. We did it both open and laparoscopic, and about 11 of them were positive pre-op for COVID-19. So again, this is about less than 10%, about 8%. If you look at HBP, so it was 7 out of 55, so which is about 12%, and one of them contacted COVID post-op, and this is the gynae, again. So the figures were about, say, around 10%, of the patient on the screening test were positive. So we had to delay their operation for 2 weeks. We initially did it for 2 weeks, and then in some of the cases, we realized that maybe 2 weeks is not enough. So at later stages, we stretched it to the 3rd week as well, and used to operate on them after 3 weeks. This is the orthopedics, again, ortho-oncology mainly. So again, another 10%, and one of them got COVID in his post-operative period. This is head and neck surgery. They did quite a few emergencies as well. And this is urology. Again, about 39 out of the 476. So it's nearly the same percentage. Neurosurgery, we did quite a few emergencies there as well. 17 emergency cases, total 35, and 2 were positive for COVID on pre-op testing. So now coming back to this screen, overall, we operated on about 99 patients who were tested positive, and about with a 10% morbidity and about 4% mortality in these patients. So in conclusion, I'll say that major oncological surgery in COVID-19 positive patient is safe, but and if you have adequate and extensive testing is required for screening, if you have that available, then you can safely start the oncological services. You need observation period for patient who test positive. You need a close post-op monitoring and strict compliance with PPE policies. And you have to continue changing the policy with the changing environment. With that, I'll come to the end of my talk. Thank you very much. Thank you.
Thank you very much for Dr. Shahid Khattak for an excellent presentation. I agree that it was a tough time for us because we were main center where COVID-19 cancer patients were treated, and obviously ICUs were all full at that time, and obviously we were under a lot of pressure from our cancer patients as well, who obviously they're in that particularly 2-3 weeks when their surgical treatments were delayed because of it. But now obviously we recovered very well, and one thing I just want to ask participants, I can see there are more than 100 participants listening to the presentation. I encourage them to ask ask question in that chat format, and I can, because we will have enough time, after the last talk for question and answer session. And I encourage all the panelists that they can, discuss issues with each other as well, because we will have time. So now I'm going to invite my last but not least speaker. He's a consultant radiation oncologist in King Faisal Specialist Hospital and in Research Center in Riyadh. He has a special interest in GI cancers, in sarcomas, and stereotactic radiation. So Dr. Athar Kazmi, kindly share your presentation. Are you there? Yeah. Okay, so Dr. Athar Kazmi, you can share your screen.
Thank you, Ridwan, for inviting me to this very important symposium. And it's a pleasure to see old friends, although even virtually. So I'm going to talk about COVID-19 pandemic and radiotherapy, impact and guidelines. So currently I'm working in Saudi Arabia, and Saudi Arabia is not new to coronavirus respiratory syndrome epidemics. Obviously, they have had MERS in the past, and that gave them a degree of experience and a bit of infrastructure to deal with respiratory syndrome epidemics. And therefore, you can see that even though the first case was diagnosed in March in Saudi Arabia, there were several public health measures that had begun even before that. And as soon as the first case was diagnosed, there was a significant escalation of those measures. There was an establishment of national COVID-19 task force. There was implementation of strict social distancing and masking. There was actually a very strict curfew in the initial few weeks of the COVID-19 pandemic. Given that Saudi Arabia has a unique place as the site of, as the location of the two most holiest Islamic sites, and there's a huge amount of religious pilgrims that come to Saudi Arabia every year. It was a huge and I think brave decision to actually stop religious pilgrimage and focus on containing the pandemic. And with all these measures, Saudi Arabia did pretty much well, although there's still quite a high number of cases, but I think it was quite better compared to several of the other countries, particularly in the developed countries. And so far, we haven't seen a second wave, thank God, and we are bracing for it. But so far, the social distancing and the public health measures are holding their own. Also, the mortality rate in Saudi Arabia have been pretty low, and that's a relief as well. In terms of radiotherapy, we know that radiotherapy services were impacted significantly from the epidemic. This is a study from Wuhan, China, the heart of the pandemic, and that shows that in January, before the lockdown measures, the number of patients attending radiotherapy was significantly reduced when the lockdown was imposed. And although the patients were encouraged to come back, less than almost half the patients did not come back to continue radiotherapy, and that reflected because of either disease or progression disease, or patients being fearful of getting to that area because of risk of contracting the virus. A similar study from India, it's a large cancer center in India, showed that with the implementation lockdown, there was a steep drop in number of treatments, and even when lockdown was back, the numbers did not recover quickly enough, and therefore there was this issue of a delay and interruption. The global radiation oncology community was quite responsive to the pandemic, and there were several national and international guidelines that were developed quite soon, actually by March and April. Obviously, the Saudi National Cancer Institute developed its own guidelines. There was this guideline from the German-speaking region, guidelines from Iran, the Royal College of Radiology in UK, and the NICE, National Institute of Clinical Excellence in UK. And there were several consensus statements from American Society of Radiation Oncology, and European Society of Radiation Oncology, and they published all these resources. And one of the best things was that these are all open access material, and therefore could be accessed by anyone. And these guidelines, including our own guidelines in Saudi Arabia, pondered over a number of challenges specific to radiotherapy, but also some challenges that were shared across other specialties. So as has been pointed out before, cancer is a big killer, and radiotherapy is essential treatment for several cancers. We know that treatment delays, particularly radiotherapy delays, are detrimental to outcomes. We also know, as I think Dr. Shaukat was pointing out, that there was a reluctance to perform surgery during COVID-19 pandemic, and therefore there was this trend to refer patients for radiotherapy more, because radiotherapy was considered to be safer, as it did not have the systemic immunosuppressive effects of chemotherapy or the risk associated with surgery. And therefore, the challenge for radiotherapy during the pandemic was that there was actually a potentially increased demand. We also know that treatment interruptions in radiotherapy are critical outcomes, and they are detrimental to efficacy. On the other hand, we do know, as has been pointed out, that cancer patients are more likely to be infected or co-infected, and also have a much worse outcome from COVID-19. We also know that although radiotherapy is a local treatment, its toxicities can increase susceptibility to infection, high-risk complications. For example, if you are doing thoracic radiation, or you're radiating large areas of mucous membrane that result in mucositis and breakdown of mucosal barriers, or you're irradiating large areas of central skeleton, resulting in myelosuppression. Also, the radiotherapy team comprises of very specialized and trained staff. So particularly the radiotherapy technicians are hard to come by, and it's very important to protect those staff, not only to avoid cross-infection, but also to avoid department shutdowns and complete cessation of service. We also know that radiotherapy is a unique treatment, that it is given over several days and weeks, and therefore there's a bigger window of exposure to the staff and to the patients who are getting infected and cross-infection. These patients require close physical interaction with the radiotherapy technicians during planning and during treatment, and social distancing is not always possible, and therefore appropriate PPEs are crucial. There is a shared place of planning and treatment, the treatment rooms, the planning rooms, the CT planning, the LINACs, and a typical LINAC would treat anything between 30 to 80 patients a day. And therefore, with this workflow, the importance of cleaning up, wiping down, avoiding cross-infection becomes very important. Obviously, these patients require regular monitoring, clinical assessment in clinics, and since radiotherapy services are usually concentrated in specialized centers, patients have to travel and have to find accommodation, which becomes very relevant in areas of lockdown or where travel restrictions are in place. So these challenges, based on these challenges, several guidelines developed risk reduction strategies. I think there was a consensus globally in the radiation oncology community that radiotherapy had to continue. I think we realized that cancer was a big killer, that cancer patients deserved the best care that we could offer, and it was not practical to completely stop radiotherapy services. But obviously, there was a need to develop and implement appropriate risk reduction strategies. And before I try and summarize the various strategies that we in Saudi Arabia and internationally were recommended, I think it's very important that these have to be implemented in the context of local circumstances and resources. For example, the availability of personal protective equipment, the testing capacity and robustness of contact tracing and quarantine in your particular environment. What is the patient population that you see? And what are the workflow practices? And can you modify them to reduce the risk of cross-infection? And also, you have to follow the regional national policies. So the Saudi Arabia National Cancer Institute, which was part of the national program and task force for the COVID-19, developed these caregiver and facility clinical practice guidelines. They were published fairly quickly, and in March, they were developed by the group of experts taken from across the country, from various cancer centers. And they were very comprehensive guidelines. They looked at the general preparation and advised about what to do with the management and setup of the cancer centers. For example, setting up a COVID-19 steering team and screening procedures for patients, ensuring that the PPEs were provided, advising all staff to get N95 testing, assigning staff to provide adequate testing centers within every cancer center. And in case of lockdown, and in Saudi Arabia, there was actually quite a strict curfew. There was it was quite an important aspect to allow staff and patients to continue to travel, and therefore special permits were given to staff and patients for that, particularly cancer patients. There were quite detailed guidelines about how to limit the flow of patients and potential infection into the centers, and therefore, for example, the access was limited to one where it was screening, the symptom questionnaire and temperature check. The vendors and visitors were restricted. There was a development of virtual support services, development of telemedicine and clinics. There were triage stations at the day cases, at the day clinics, and the radiotherapy units to ensure that anyone displaying symptoms was quarantined and isolated quite quickly and then tested. The seating areas were obviously modified for social distancing, and the chemo bay area was modified to ensure social distancing. There were specific, I think this is one of the most important areas of these guidelines, that there was a very robust and detailed guideline about how to manage healthcare potential exposure in healthcare setting. And this is just an example of the detailed guidelines. So it looked at the level exposure, the duration exposure, the circumstances exposure, what sort of PPEs were developed, and based on that, guidelines were given whether the healthcare professional needed quarantine for 14 days, needed testing, and could even actually quarantine for less period of time and get early testing and come back. So there was a very pragmatic and quite a clear guideline to maximize the utility of staff as well as reducing the risk of infection. And then there were obviously guidelines for actual management, both from systemic chemotherapy and the radiation therapy point of view with patient prioritization. I'll come back to the radiotherapy bit in a moment. So at King Faisal Hospital, where I work, radiotherapy services were interrupted for 1 week, right at the start of the lockdown and curfew, but then we resumed quickly with the prioritization categories, which we'll come to in a minute. Despite the quick resumption, almost 50% of patients had a delay of more than a week, and that was related to patients traveling back to remote areas and then unable to come back, or patients fearful of coming to the main cancer center for risk of infection. And the radiotherapy department in the city actually had to be closed down completely for a few weeks due to multiple staff infection, but we thankfully spared that. So what are the risk reduction strategies that are specific to radiation therapy for reducing COVID-19 infection. And one of the strategies that we adopted was tandem operations team, and that's actually not unique to radiotherapy, but since we are a very specialized service, we divided the radiotherapy technicians into two teams so that they worked completely separately and had no physical contact with each other. And the benefit was that with a smaller team, if any one person was identified as being positive, the circle of spread was low and the impact on overall continuation service is low. So we developed this quite early on in our service. In terms of the practical radiotherapy planning aspects, our physicists and dosimetrists took guidance from several international publications, for example, looking at radiotherapy plans that reduce the time radiotherapy spent in the room, for example, minimizing beam angles which required couch kicks and therefore manual movement of the patient, or required manual insertion of accessory like wedges, so that the RTTs could reduce the time that they had in contact with the patient during treatment. Also, for example, avoidance of gated breath hold techniques, which required extensive therapist effort and involvement. Invasive procedures like insertion rectal balloons, prostate treatment were avoided to minimize aerosol generation and risk of infection. The patient status was checked before the actual patient was on the couch to ensure that there was no gantry collision and no requirement for manual couch movement during treatment. The on verification treatment, Khanum CT obviously is a better modality of checking verification of radiotherapy, but we optimized its use and mixed it with the orthogonal KV imaging to make sure that the treatment times were reduced. And we also schedule all patient-specific QAs over the weekends to reduce patient exposure to the physicists. In terms of the clinical radiotherapy side, the prioritization was based on tumor biology and clinical need. And actually, this is not something that is completely new to radiation oncology community, because we are, as a radiation oncology community, used to machine breakdowns and interruptions. Therefore, there are already strategies in place to reduce the risk of treatment interruption, the treatment prolongation. And there's a body of evidence looking at what tumor biology needed prioritization for radiotherapy as opposed to something that could be delayed or deferred. The main, after the prioritization, the three main pillars of radiotherapy practice was avoidance, deferral, and shortening. So in the early days of pandemic, when there was this expectation that the pandemic would hopefully be over in a few months and there would be a chance to return to normal work practice, several low-risk cancers for whom the radiotherapy could be avoided was either told not to have radiotherapy or deferred. For example, they could be done after a few months, and we'll come to the specific examples in a moment. And the third option was to try and reduce the radiotherapy fractionation schedules so that the overall window exposure was reduced, and that was achieved by giving a bigger fraction on a day and reducing the overall treatment time, what we call hypofractionation. Again, this is not something that is new or unique to the radiation oncology community. Traditionally, the hypofractionation and shorter treatment schedules has been driven by treatment capacities because radiotherapy facilities are almost always overwhelmed. And so again, there's a body of evidence looking at hypofractionated schedules, their benefit and risks, and therefore this was quite important for the radiation oncology community to be able to recommend guidelines based on existing evidence. I think it became clear after a few months that COVID-19 was not going anywhere soon, and therefore there was this shift from the avoidance and deferral to how we can receive radiotherapy safely with all the infection control practices and other guidelines. And obviously, all of this had to be as much evidence-based as possible. So this is from the Royal College of Radiologists recommendation. This is something that almost every radiation oncology trainee or consultant knows for the last several decades, that we know that there are certain cancers which are designated category 1, where delay and interruption of radiotherapy reduces outcome significantly. And these are the cancers which are squamous cell cancer of the head and neck, esophagus, skin, cervix, vulva, vagina, and anus, also esophageal adenocarcinomas, lung cancers, both non-small cell and small cell, medulloblastomas and peanuts, and also other tumors with rapid proliferation and short mass doubling time. So these cancers really take precedence and priority when you talk about allocating radiotherapy services, because essentially these patients will have a significant detriment of outcome if you delay or defer or interrupt the radiotherapy. In category 2 are the patients that are being treated radically, but who have slow growing cancers, and the deferral or interruptions do not have as much impact on the treatment as category 1 cancers. Still, you don't want to prolong their treatment too much, but in most cases, these patients can have an interruption of up to 5 days without too much detriment. And obviously, category 3 is the palliative radiotherapy. So these guidelines, the Saudi National Cancer Guidelines, actually were our own hospital took a lead in developing these prioritization for radiotherapy patients in our hospital, and then these our local hospital guidelines were incorporated in the National Saudi National Cancer Institute guidelines. And basically, we said in the initial phases of the pandemic that we'll treat only priority 1 and 2 patients, and will be delayed for 3 weeks. And priority 1 patients were basically category 1 patients, those are all college tumors, and also where there was a planned fractional beam and brachytherapy afterwards, which is mostly cervix and some prostates, but mostly cervix. The priority level 2 was emergency palliative spinal cord compression, where there was still neurological function and which we salvaged. For the rest of the priority levels, the radiotherapy was deferred, and these were patients like, for example, breast cancer, prostate cancer, rectal cancers, and also adjuvant radiotherapy for breast cancer. Palliative radiotherapy was stopped, and other palliative measures were instituted for pain control, for example. The adjuvant radiotherapy, where there was complete resection of disease, was kept at the lowest level of priority, and prostate patients who were already on the adjuvant hormone treatment. So based on this model, we were able to receive our radiotherapy services fairly quickly, but obviously this model worked for a period of time, and we realized that with the prolongation of the pandemic, we could not continue to follow deferral and avoidance model indefinitely, and therefore over the last few months, actually, there has been a gradual return to nearly normal levels of radiotherapy service, and we are now treating almost everyone except for low-risk breast cancers and prostate cancers, and with all the appropriate precautions. So fairly similar guidelines were recommended by other national organizations. This is the guideline from National Institute of Clinical Excellence in UK, and then it follows a similar pattern. What to do with the management of treatment interruptions? Again, guidelines for this were already available, and further guidelines were issued by the Royal College, by the American Society of Radiotherapy and Oncology. And essentially, the gist is to transfer to the machine, treat over weekends, treat twice daily, and if that's not possible, then calculate a biologically equivalent dose for patients, or add extra fractions at the end of treatment. And basically, this applied mostly to category 1 patients, for whom even a smaller, even a shorter prolongation of treatment time has a detriment of outcome. But even for category 2 tumors, if you have a interruption of more than 1 week, then these guidelines apply to these patients as well. What did we do when we were confronted with the COVID-19 positive patients who needed radiotherapy? So patients who were on radiotherapy, if they developed typical COVID-19 symptoms, the treatment was interrupted, and testing was done. And until the test results were back, the treatment was not continued. If they did test positive, then duly the decision was based on the indication of treatment, the resources available, and the performance status of the patient. And essentially, if we could not guarantee adequate patient and staff safety, then we discontinued radiotherapy for these patients. And to be honest, in most cases, these patients could not receive radiotherapy until they were negative for COVID-19, and therefore these patients had a discontinuation of radiotherapy. International guidelines recommend that COVID-19 positivity is not a reason to discontinue radiotherapy per se, but again, they emphasize that adequate patient staff safety is essential, and if this cannot be guaranteed, then you have to discontinue treatment. What to do if you have a patient who's COVID-19 positive before you start treatment? And general agreement is that these patients should have a delay of the treatment until they have recovered, and generally speaking, unless it's a clinical emergency, a delay of up to 2 weeks is manageable in most clinical conditions. In the rare situation where the radiotherapy continued for COVID-19 positive patients, quite a strict degree of infection control measures had to be followed. There was a PPE for the staff, obviously, but also thinking about how the patient gets from its, for example, the hospital patient or the quarantine unit, or the isolation unit, to the active radiotherapy machines. And if there are risks of exposure to other people in transit, then it's not feasible to continue radiotherapy. But obviously, if patients were, for example, admitted in the ward and there was a way to transfer them safely to the linear accelerator without compromising other patients or staff, then this was done with the specific access route, and these patients were treated at the end of regular treatment schedules. And obviously, there were SOPs for sanitization, cleanup of the equipment and facility after that. Once a patient had recovered from COVID-19 infection, again, local infection protocols have some variation. Usually, our protocol was to ensure 10 to 14 days of quarantine. They had to be asymptomatic for at least 72 hours, and they had to have 2 consecutive negative SARS-CoV swabs. And after that, I think it was essential that they were seen by the treating team, the treating radiation oncologist, to assess fitness, because it is quite possible that if they had suffered significant morbidity with the COVID infection, they may not be fit to continue treatment, and the clinical decision had to be made as to what to do about this. The other thing to watch out for was, for example, if you were planning on thoracic radiotherapy, this patient recently recovered from a COVID-19 related pneumonitis or significant upper respiratory tract infection, and you're treating head and neck. So you have to be careful that you do not worsen or the recent complications and allow patient adequate recovery time. So I'm going to try and summarize some of the site-specific recommendations that have been made by the international bodies. And it's just, I think the detailed recommendations review is beyond the scope of this presentation. And I think there are, as I said, several resources available online with open access that we can access. But the point of showing these guidelines is to illustrate the process by which these guidelines are developed. And mostly these are collaborative guidelines. You have to remember that these are emergency guidelines, and they are evidence-based as much as possible, but they are not to be used as a replacement for normal standard treatment. And therefore, as soon as you're able to go back to your normal workflow, you have to revisit those guidelines and try and come back to the standard treatment as much as possible. So as an example, this consensus statement published by the American and the European Societies of Radiotherapy and Oncology on head and neck cancer used an iteration model in which a series of questions were sent to head and neck oncology, radiation oncologists across the world, and they were asked for their opinions about what they felt regarding the management of head and neck cancer. And there was a strong agreement. There was a recommendation based on that agreement. For example, there was strong agreement that we should not postpone the initiation of head and neck squamous cell cancer radiation therapy by 4 to 6 weeks. So a short delay of up to a few weeks was agreed on, but a longer delay was clearly detrimental to the cancer outcome, and therefore most radiation oncologists felt that this was not appropriate. And then these patients had to start radiotherapy with adequate protection and infection control measures. They also felt that radiotherapy for head and neck cancer is high priority. For example, look at the second table. Delay initiation of radiotherapy until recovery of SARS-CoV test is negative. So most people agreed that resumption of radiotherapy for head and neck cancer, because of the high doses, because of serious toxicity to the mucosal membranes, resumption of radiotherapy until adequate recovery from COVID was essential. So you could not rush the resumption of radiotherapy in a COVID-19 positive patients. So looking at this table here, there was some agreement, there was some suggestion whether a hypofractionation or altered schedule of head and neck radiotherapy was used, but most people felt that we should not alter the standard head and neck radical radiotherapy. The standard radiotherapy for head and neck lasts about 7 weeks, and even if you hypofractionate it, it will still last something between 6 or 5 weeks. So therefore, it's going to be difficult to change that a bit. Similarly, for lung cancers, there was this recommendation to try and deliver stereotactic radiotherapy in as few fractions as possible, and there were recommendations for organs at risk dose constraints published by the Royal College of Radiologists. The small cell lung cancer, the early lung cancers were recommended to be treated with stereotactic radiotherapy, and limited stage could be treated with a hypofractionated schedule of 3 weeks rather than a traditional 4 or 5 weeks. For breast cancer, the low-risk breast cancers were recommended to avoid radiotherapy. So patients more than 65 years, smaller tumors, clear margins, ER positive, and who had the option of endocrine therapy. This is based on the primary trial that showed that although the risk of recurrence was slightly high, it was still quite low in these group of patients. DCIS radiotherapy was avoided. For standard adjuvant, no negative radiotherapy, the fast-forward trial came along fortuitously at the same time as the pandemic, and that showed that a hypofractionated 1-week schedule of 26 grade 5 fractions was actually superior for local control than the standard schedule, and therefore this was adopted for most patients in the node-negative setting. For prostate cancer, watchful waiting, active surveillance was recommended for most patients. The neoadjuvant hormone therapy, if it was already in place, could be continued for several more months. But even in patients who were not on those, could be followed up for a period of time. This was further updated by a study that came out recently, and that showed that patients who had even high risk or intermediate risk prostate cancer, delay of radiotherapy up to 6 months after a neoadjuvant hormone therapy did not result in any worsening of survival, and therefore it's quite reasonable to delay that. For rectal cancer, most people know that rectal cancers, there's the standard treatment of long course chemoradiation for locally advanced tumors versus the short course radiotherapy for early tumors. But in this time, the European Society of Medical Oncology and Royal College recommended that short course with delayed surgery could be used even for locally advanced tumors to reduce the risk of recurrence. And this is based on at least 2 trials, the Trans-Tasman trial and the Polish trial, that have shown that short course radiotherapy followed by delayed surgery provides fairly reasonably equivalent local control to chemoradiation. So therefore, hypofractionation delay for rectal cancer was recommended. So obviously, as I said, all these guidelines have adapted to the fact that COVID-19 is with us for the long haul. We are hoping for a vaccine, but at the moment, we are not sure how effective it would be and how long will this pandemic continue. And therefore, we have to switch our focus from the initial phase of deferral and avoidance to the recovery phase. And therefore, we have to develop strategies where we can recommence treatment with adequate infection control and where the benefits outweigh the risks. We have to restore our services, particularly radiotherapy services, to ensure that we can continue to deliver quality assured, high quality radiotherapy. And we have to learn from the lessons from the pandemic and look at the evidence critically as to whether we can continue some of the practices that we started during this pandemic. So in conclusion, Radiotherapy is an essential cancer service and should continue during COVID-19 pandemic. Appropriate patient prioritization and risk reduction is required to protect patient, staff, and general population. Continuing or starting radiotherapy in a known COVID-19 patient is generally avoided. Resources and guidelines with increasing evidence base are available, but implementation of specific strategies depends on local resources, requires multidisciplinary involvement. Obviously, patient-related factors like travel, accommodation have to be considered in this scenario. Thank you very much.
Thank you, Dr. Atar Kazmi, for an excellent presentation. I appreciate the most important point, obviously, was our ability to reorganize our services. And the other important was the ability to prioritize and to come up with a model where we can treat this curable cancers as a number one, and then obviously prioritizing other patients and also assessing their risk. Thank you. This is an excellent talk. I have a lot of questions coming up now from the attendees. This is Muhammad Asif. He's asking to the Dr. Shahid Khattak, did you advised post-op isolation for your surgical patients?
No, not particularly. Well, I mean, how you define isolation? I think we have actually 2-bedded rooms, for our post-op patients, and we kept it 2-bedded rooms, so we didn't do that much. But obviously, we tested them pre-op 48 hours, within 48 hours, and after the operation, we just. I mean, it was just like what we will do for our routine patients. They went to the shared rooms. Obviously, our hospital has got a very, very strict mask policy. So any staff who was going there, made sure that they covered, they're wearing masks, but not specifically for those. If they got any symptoms which were worrying, that they can be COVID, yes, definitely. They were straight away seen by the ID team, and then they were isolated and they were tested. And as I said, we had hospital had a complete red areas and green areas. And so, if the surgical floor, the elective surgical floor was green. So if there was any patient who was symptomatic, we used to move that patient from the surgical floor. And then, yes, we used to isolate. But otherwise, no, not routinely. I hope that I've answered the question. Yeah.
Great, thank you. So there are a lot of questions coming up. This is great. It was the thought-provoking presentations. So Najmuddin, he's asking that how would speaker change their practice in second wave after learning from the first experience? This is Professor Syed Hussain, if you can answer this question.
I think what we've learned, and again, these sort of sessions are great in helping and having a more like a thought-provoking discussions, really. What we've learned, initially when this started in March, April, there was significant variation in practices, and that has come out more recently. The harm perhaps that has come to patients as well because of delayed diagnosis and things, that will come out in years to come as well. And I think what is key here, what we have learned from it, and it was, hearing from my colleagues from Ireland, from Saudi Arabia, from Pakistan, it all helps us to understand that actually how we could continue with services where there was a higher impact to outcome of patients, to harm to patients. And that's where earlier treatment and giving them treatment, as we have worked over the years with clinical trials, telling us the significance of chemotherapy, the importance of chemotherapy in improving survival. So the first guidelines that came in March, April, what you will see, what we have learned from this pandemic is in the new wave that is coming through, we are not seeing the similar sort of guidelines coming through. People are being encouraged to continue with diagnostic services as much as they can, because we have learned that in the last wave, I think there may have been delays in treatment, which may account for poorer outcome for many patients. So I think one thing which I will highlight, that there was a lot of hypothetical concerns, and even for oral treatments for prostate cancer. I remember some of the colleagues, even in, some of my colleagues in UK and other parts of the world, where they were worried about drug interactions, that if I give this drug, if there is a interaction, and if this patient comes in and then gets COVID. And I used to tell them, look, these are so many hypothetical scenarios. What you definitely know is that advanced cancer will kill the patient. And I think this is something that has come very strongly from this session. And I think, again, all sort of, I'm delighted that you guys put that as a focus session. But that's where I feel that we have learned from that pandemic, and I hope that that will help us as oncology community to continue to treat our patients globally, not just in one part of the world, but globally. And we will see patients being treated, because we are not seeing any harm coming from treatment to patients or visiting the hospital for treatments for patients. Again, the normal precautions will have to be taken. That has to be dealt with very strictly and very carefully. But at the same time, I think we should continue with treatment as much as we can.
Thank you, Professor Hussain. So this is Najmuddin. He's asking to Dr. Shahid Khattak again. It is interesting to note the difference in practice in handling COVID pandemic. Most of the general public hospitals understandably had to take on treatment of these patients. However, it is not understandable why a pure tertiary care hospital would opt to convert into a COVID hospital and shut down cancer care service. Do you think it was the right decision?
Let me first clarify. We didn't shut down the cancer service. That is a completely wrong impression. The chemotherapy unit was working all the time. The radiation department was working all the time. And I just explained in my talk, that we stopped elective surgery for some limited time. And it's always easy to be clever after the event. What was happening just imagine what was happening in end of February and March. Nobody knew what is going to happen in this country. And we were looking at Italy, we were looking at London, and obviously being a premier institution, as I said, we had a very good laboratory. So we initially provided the government help for the testing. And then, at that time, we didn't know how many ICU beds will be needed. These are very, very difficult decisions. And Shaukat Khanum being, as we had a very good ITU, we are proud of our intensive care and our intensivist. We had a good anesthetist, we had about, I think, 13 or 14 consultant anesthetists. So that's why we thought that we will take the patient who need ventilation. We will help the government and the community, in this pandemic. And those decisions were made. But chemotherapy was going on all the time. Radiation was going all the time. And elective surgery was only stopped for about, say, 2 weeks. After that, we gradually started with the breast work. And let me tell you one thing as well. I mean, when now we are very clever, but in March, literally, I was one of the strong, voice that we should not be doing major surgeries, because at that time, Athar is sitting here, most of my patients, as I said earlier, I have got chemoradiation, there's esophagus guys and the guys with the rectal cancer. We usually operate on them with from 6 to 12 weeks window, or maybe nowadays even more than 12 weeks. Some studies recommend that you leave them for more than 3 months. And if I thought in a start of March that if I'm a patient and I have received my chemoradiation for rectal cancer, and now it is, say, 8, 9 weeks or even 10 weeks post-radiation, will I like to go for an operation at this time? My answer was no, I don't want to, I want to be tested. I want to make sure that I don't have COVID disease. And then, or for some reason, if my operation has to be delayed for 2 weeks, I will go for a delay for 2 weeks. So the impression is completely wrong that we stopped the cancer services. the reason of postponing the surgical services was multifactorial. I hope I answered the question.
Excellent. Thank you, Dr. Shahid Khattak. This question to Professor McKean. What suggestions you have for us here in this part of the world where we have limited resources and people are not that cooperative due to low income issues and stuff? Um, Obviously, it is relating to cancer care in a third world country. This is the attendee have written a name for yourself, Professor McKean.
Well, thank you for that. So is the question, Rizwan, do you want answered about COVID or about cancer care?
It's cancer care.
Okay, well,
with the limited resources. That is what he is asking.
My own thoughts in terms of cancer care with limited resources are that its focus should be the maximum impact for the least cost, where you have limited resources. I think that's fairly basic. By definition, therefore, if you're to ask me what the very best things to do, they're around prevention. So a stopping smoking program is the single best impact that you can do. So that is where I would focus, rather than necessarily focusing on high expense, high risk therapeutics. If you're asking me in terms of the management of a cancer that presents, I would think the focus needs to be in surgical oncology rather than in medical oncology or in radiation oncology. Because again, in terms of long-term impact for best benefit, that's really where the focus needs to be. If I was to answer the COVID question, the core of everything everybody has talked about today is 19th century medicine. It's about keeping social distance and keeping hand washing. That remains the core of the management of infectious diseases. I personally don't hold out much hope for a good vaccine. We've had coronaviruses for 40 years that we've been aware of. We still don't have any vaccine for any coronavirus that's any way efficacious. And some of these are fairly lethal diseases. I think that what we have got better at is the management of COVID as we have gone forward. Exactly as Dr. Khattak said, and I agree completely, up front we didn't know what we were dealing with. In Ireland, on March 20th, if you were over 80 and you got COVID-19, you had a 1 in 5 risk of death. If you got that same disease today, on November 6th, you will have a 1 in 20 risk of death. So we are substantially better at managing this condition. I think what we need to do is we simply need to continue to manage cancer exactly as Dr. Hussain said, as we have always been doing it. And we need to continue to mitigate the risk in terms of COVID by social distancing and hand washing, however that may be implemented in your services.
Excellent. Thank you, Professor Keen. So the next question is again to Dr. Shahid Khattak. How did the anesthesia department supported you in surgery of COVID or non-COVID patients in COVID era, and how did that help you in your surgery?
Well, I think, as I said, we did numerous meetings, before, during, I think the time of end of February and start of March and going on to April. And it was a coordinated effort, and an anesthetist, anesthesia team were always, on board with the surgeons in the decision-making that whether to delay the operation or whether to do it. I think in every good hospital, the surgery and anesthesia department very closely work with each other. So it is not only that in COVID patient that you need collaboration between surgery and anesthesia, and really in all the routine work, So it was exactly the same. I don't think so that we had any problem that we actually operated on COVID positive patients as well, and took all the precautions, the PPEs. I think Raza did a couple of tracheostomies on them, but took the full PPEs and that's it. So no problem.
Okay, so another question. This is for Dr. Syed Atar Kazmi. So this is from Muhammad Abid. What should be done if patient developed symptoms of COVID-19 during chemoradiotherapy treatment of a head and neck and cervical cancer?
Okay, so yeah, I think as I said in my presentation, COVID-19 positivity is not an automatic disqualification or continuing of treatment. See, if patients are otherwise well and it's an incidental finding, and you can ensure patient and staff safety, then oncologically it's better to continue. In practical terms, for example, what we did here was that we could not ensure that these this infection control, infection control measures, patient transfer to and from the units in the machine was feasible, and therefore we did not treat these patients, and these patients had a break of their treatment, and therefore then you come to the area what to do once they've recovered and how you will compensate for the gap and all that. So the practical answer is that in most cases, unless there are very robust and very clear pathways for maintaining infection control in these positive patients, you can continue if they are taking well and do not have the typical pneumonitis or severe symptoms. But in otherwise, practical terms, it is difficult. I'll let medical oncology colleagues answer the question about chemotherapy benefit, but generally weekly cisplatin is not that myelosuppressive or toxic in most patients.
Okay, so my next question is to Professor Syed Hussain. What is your view about risk of getting COVID-19 infection and its complication with the use of checkpoint inhibitors immunotherapy?
I think that's a very interesting question. I think we know very little. And one thing I will just, before answering this question, I would just want to clarify on one thing. Whatever colleagues did between March to June, I have to say everybody did the best for the patient and did the best for the healthcare. That's one thing I want to very make it clear, because even in UK, we had significant variation. Some of my own colleagues did not treat patients because of the concerns. And I always say that we never knew there's nothing about right or wrong here. It was more to do with what we felt was in the best interest of the patient. So coming to this question of immune checkpoint inhibitor, again, I had patients who were on clinical trials. I had very clear discussions with them because there was an issue about whether immune checkpoint inhibitors will increase cytokine release syndromes, whether immune checkpoint inhibitor treatment, if you get toxicity, you will get, and then you will be using steroids, which was initially caused to be of a concern, though in future, later on, we found out that actually it was one of the best regarded treatments in those sort of cases. Use of steroids. So I think immune checkpoint inhibitors, personally, my opinion is that I think you have to look at the risk benefit in each and every case individually. I don't think you can have a consensus guideline to say each and every patient where immune checkpoint inhibitor is allowed, in a sense, you should use it. But in most cases, you will see that in second line setting, in advanced bladder cancer, in other tumors as well, there's a significant benefit with the use of immune checkpoint inhibitors in controlling the disease, improving the durability of responses, and even improving survival. So I think in those cases, when you look at the risk-benefit profile, in my view, you may find that benefits will outweigh the risk. But again, it's a very individual discussion, and also very individual discussion with the patient, where the patient may well have significant concerns about even coming to the hospital for infusions or for injections or seeing you. And I find it difficult, teleclinics have been brilliant, but in borderline cases, it is difficult to assess fitness of patients on the phone. And sometimes when you're giving these treatments, especially during those pandemics where the concerns and the risks are there as well, it's important to assess them, discuss these things, and help make patient an informed choice. That's what I always try and recommend, that if you spend time with the patients, you'll be surprised how many times they will make the informed choice, and that will be the right choice for that patient. And I think that is what I will recommend here as well, that we have learned more about immune checkpoint inhibitor toxicity. As I showed in my data, a number of patients had immune checkpoint inhibitors. 3 of them had toxicities as well, grade 2, and even one of them had grade 3 immune-mediated hepatitis, treated with high dose steroid, tapered the dose of steroid, and then we were able to treat them again. There is another paper in European Urology as well, which has looked at the use of immune checkpoint inhibitor in kidney cancers. And again, that very clearly showed that even patients who got COVID positive, once they had tapered the dose with steroids, they were able to re-challenge them with immune checkpoint inhibitors again. So I think those sort of data is giving us more confidence and more sort of reassurance when we are treating them.
Just 4 minutes left, so I will have my second last question. I'll ask to Dr. Shaukat. Have you noticed impact of postponing elective surgery on the progression of disease in your practice?
Well, again, the answer will be yes, but I think the progression is multifactorial again, and just by postponing the surgery for a few weeks, I don't think so. Just like I gave the example earlier on, that most of our patients are post-chemo radiation patients. Esophaguses, stomachs are post-chemos, rectums are post-chemo radiation. So a few weeks of delay is not going to make that much difference. Obviously, the colons need to be done straight away, So few of the colons, I'm sure that they have progressed. But the real problem with the progress of disease is, I don't think so, delaying the surgery. The COVID impact is, again, on the whole community. In our country, because although we didn't do the very strict lockdown, but still it was a lockdown. There was a problem with the transport. Shaukat Khanum is a charity organization, and 90% of our patients are poor patients. So coming to the hospital, they need a public transport. So that was, I think, if there was a delay or progression of disease, it was mainly because of the lockdown, because of the patients couldn't come to the hospital because of the transport problem. And again, Athar is here, and that quite significant proportion of our patients, especially in the upper GI, come from across the border from Afghanistan. And during this time, because of the restriction, the borders were closed. So I have seen the impact of it, because now the patients are coming up who, because of the borders were sealed, so their disease have progressed. So it is not one factor.
Thank you, Dr. Shahid. Sorry for interrupting you, because we have 1 minute left. I just want to thank everyone for giving such a great presentation. And last but not least, I would like Professor McEnkeen to give a concluding remarks for this session.
Again, thank you to everybody for what I believe has been a very informative session, a very informative international session. And I think the keys for me from this have been that we have all been learning this on the fly. I also think it's critical that we continue to learn and continue to share information, and share information rapidly as this disease evolves and as we get into second waves, because that allows us all to benefit from each other. And it's interesting that we've all really come largely to the same conclusions. I think the critical thing for all of us is to continue to practice evidence-based medicine on the basis of the evidence that's happening in front of us. Because there has been, and I think Dr. Hussain described it very accurately in terms of the UK, a lot of fear-mongering around, and particularly patients have suffered from that, and particularly in the public media, where they've had a greater fear of a disease they haven't got than a disease they have got. And we need to treat the disease they have got, and we need to manage the disease they haven't got by appropriately applying the evidence we have. There's a lot to be said around testing, PPE, and all of that, but I think the core of this thing is prevention. I think all of us are going to be living with this, I would expect, for the next 4 to 5 years in various iterations. I think what we're going to see is like a trickle down, where we had a very big event initially in our March, April event this year. We're in the second wave now. I fully expect that we will, and certainly in Ireland, we've already turned the corner here. I expect our next wave is probably going to come in February and then in the summer of next year. And at each time it's just going to get a little less. But what we need to do is ensure that our healthcare systems cope robustly. I think we've actually moved now predominantly from the management of the patient with COVID to the management of the service within the context of COVID. And it really is about maintaining our staff and maintaining our services. I think we're actually quite good, even already, at managing the individual patient. And that's a credit to everybody who's involved in this symposium indeed. But thank you again.
Thank you all. Thank you, and stay safe, and keep yourself safe from COVID. All the best.
Thank you.
Take care. Good luck. Bye-bye.
Thank you. Bye.